Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Dr. Karen Straube-West. In today's episode, we focus on how to differentiate HIV RNA blips from persistent low-level viremia and from virologic failure, and what to do in each scenario. To answer these questions, I'm joined by Dr. Brian Wood from the University of Washington. Now let's get started.
So for people with HIV who are taking ART, any detectable HIV RNA, which is also called a viral load, can cause significant consternation and confusion and stress and anxiety. And this includes both for the patient and for the provider. And I have definitely had instances in my clinic where this has come up and has been very stressful, both hard to explain and hard to sort out in terms of why the viral load had risen. So in clinical practice, I think it is really imperative to differentiate HIV RNA blips from what is called persistent low-level viremia, and especially from virologic failure. These distinctions are really critical both for counseling patients and for making HIV management decisions. So let's start with what are blips. This term is used a lot, it's thrown around a lot. I think it's really important to know the actual definition. So a blip is a transient increase in the HIV RNA. Again, that is often called viral load. And it's an increase from undetectable or detected below the limit of quantification of the assay you use to a detected quantifiable level, but generally less than 200 copies per milliliter. So again, it's a viral load or RNA that goes from not detected or detected below the limit of quantification up to a detected level below 200. Rarely, you might see a blip that reaches a slightly higher level, but generally, I consider a blip to be a transient detectable viral load below 200 copies. Now, according to the Department of Health and Human Services guidelines for treatment of adults and adolescents with HIV, approximately 10% of people with HIV who take ART experience a blip each year. So if you are taking care of people with HIV, you will see this happen. Now, most blips are caused by benign biological fluctuation or laboratory artifact. Mostly they are not clinically significant. Let's turn to a definition of low-level viremia, because I think it is really important to differentiate this phenomenon from blips. Low-level viremia is a continually detected HIV RNA or viral load between the lower limit of quantification of the assay and 200 copies. The difference between low-level viremia and a blip is a blip goes right back to undetectable after you recheck it. So it's really a one-time transient increase back to undetectable or below the limit of quantification after you repeat it. On the other hand, low-level viremia is a really persistent detectable level below 200 copies. So this might be an individual who is taking ART as prescribed, but every time you check the viral load, it is 70 copies or 90 copies or 150 copies or 175 copies. And I definitely see individuals in my practice for whom this is the case. Now, a major question in clinic is, should providers and should patients be concerned about blips or concerned about low-level viremia? In my practice, I find that blips, again, one-time transient increases to below 200 copies, I find those are not clinically significant. What I mean by that is they do not generally portend virologic failure or any other clinical worsening. I find it relatively easy to reassure a patient that there is no cause for concern when a blip happens, especially because the viral load returns to undetectable when we repeat it. Now, on the other hand, low-level viremia I find to be more difficult to explain, and I find it requires a more thorough evaluation. The data concerning the long-term implications of low-level viremia is pretty conflicting, and I do not find it to be crystal clear in terms of trying to answer the question of, does low-level viremia lead to a higher likelihood of virologic failure in the future. Some studies show it does, some studies show it does not. My experience in clinic has been that low-level viremia does not tend to lead to virologic failure. It can certainly be a frequent clinical phenomenon. It can be a very perplexing occurrence. It definitely comes up in HIV primary care settings. In one study, just over 5% of individuals experienced low-level viremia. Reflecting on my own clinical practice, I think that feels pretty accurate. It is certainly something that comes up for me, not for every individual, but with some regularity. Now, the million-dollar question is what to do about low-level viremia, and I think there are a few factors to always consider. A few steps that I generally take when I see a person with persistent viral loads below 200 copies. Number one is I try my absolute best to assess for missed doses of ART, and this often involves talking with the patient, sometimes asking them to bring in their ART medications and show me how to take them. I have found some surprises by doing this. I remember a time I learned an individual had been crushing or putting their meds in a blender, and they were meds that weren't supposed to be crushed, or other surprises can come up when you simply ask a person, please bring in your pills, please show me exactly how you take them, and let's talk more about that. I also make it a priority to contact the individual's pharmacy simply to review the refill history, assess whether there have been any gaps in refills, any late pickups, anything that would raise concern for missed doses of the medications. Now, I generally find that low-level viremia occurs in the setting of adherence to ART, meaning I find that it often happens even if a person is taking their medications as prescribed. There are some data that suggest that missed doses may play a role. So I think that task number one, when you see low-level viremia, is doing your absolute best to just sit and talk with the person in a non-judgmental way and discuss whether any missed doses of the meds have happened. Again, I find collaborating with the pharmacist and calling the pharmacy and also getting collateral information from anyone else who is helping support the individual with their ART adherence, those things can be very helpful. If it really seems a person has not been missing any doses of their ART, which again does happen even with low-level viremia, other things I do are I review the patient's entire medication list, including over-the-counter meds. I look for any drug-drug interactions that might reduce the levels of the antiretroviral medications. If it's a regimen that requires food intake or has to be taken with a meal, I have a conversation with them about whether or not they are succeeding in taking it with food or a meal. I assess whether there might be barriers or food insecurity or other issues preventing that. I also assess for any reason that the individual may not be absorbing oral medications adequately. I will add, though, in my experience, poor absorption is rarely the explanation for low-level viremia. I have seen very rare instances in which that seems to be either part or all of the cause, but it's pretty rare. I also consider whether the laboratory has changed, whether they have updated their collection process, updated the assay, because those things can lead to batches of test results reporting newly detected low-level RNA values. I have seen that happen, sometimes with the transition to a newer HIV RNA assay that has a lower limit of quantification than previously used. Clinicians will more frequently encounter results showing very low levels of detectable HIV RNA. So if other factors don't seem to be at play, touching base with the lab about whether there have been changes to the collection process or the assay being used can be worth doing. If the RNA level all of a sudden seems to be detected in a low range for multiple patients in a practice and patients who never experienced this low-level viremia before, one thing to come back to the lab and just discuss is whether there has been any change to the collection and the processing protocol for the blood work. For example, use of plasma preparation tubes without certain handling steps has been associated with finding new detected low levels of RNA for multiple patients. The reason is that plasma preparation tubes have a gel barrier and they are designed to separate whole blood into different components, into plasma separated from the cellular components, the white blood cells, red blood cells, platelets. However, when agitated or stored prior to testing, the cellular material containing the proviral DNA or RNA fragments may leak into the plasma and then be amplified by the RNA assay. So this can lead to artifactual detection of low RNA levels. This can be minimized or avoided by use of standard EDTA tubes instead of plasma preparation tubes, or by centrifugation prior to running the assay. This often requires adding a second centrifugation step prior to running the test if the test is not being run right away, or another strategy is aliquoting plasma into secondary tubes before or after storage or transport. So takeaway message here is that if you're seeing low-level viremia, you've done your absolute best to assess for missed doses of ART, you've looked at drug-drug interactions, you've considered whether the individual may not be absorbing medications. Another strategy you can consider is just touching base with the lab, asking if anything has changed with their collection process or with their assay. Now, a final clinical consideration with evaluating low-level viremia is considering whether a DNA, which is also called an archive or proviral or PBMC genotype resistance test, might add useful information. So this is the type of genotype resistance assay that can be done if a person has an undetectable or very low RNA level. That said, in the majority of low-level viremia cases, I do not send this test, both because the sensitivity is low and because I find it is unlikely to change management. Ultimately, I find that most instances of low-level viremia are not caused by drug resistance. An exception might be if the individual needs to switch their ART regimen. Let's say they have a low viral load, and I know they have a history of multiple past regimens, and I suspect there might be some underlying drug resistance. Maybe I don't have records of all their past genotypes, or maybe for some reason there is concern that they might have had virologic failure, but we don't have full records. In that case, the results of a resistance assay are of greater importance. They could affect the choice of the new regimen, especially if changing the regimen from one of relatively high barrier to resistance to relatively lower barrier to resistance. So in that instance, I would consider a DNA or archive genotype resistance test. But in general, I would say with low-level viremia, I do not send that test very often. I definitely do not send it routinely. Now, if an individual has low-level viremia, the question then becomes, what do you do about it? What should your clinical management look like? So first, there are considerations just for counseling the individual, explaining to them what low-level viremia means. I find counseling for people with persistent low-level viremia to be much more difficult than counseling around a blip. I think for an individual trying really, really hard to come to all their appointments, take their medications every day, yet not seeing that undetectable viral load show up, it can be really, really frustrating. I try to help individuals in this situation to avoid feeling discouraged. I try to focus on how well they are doing with taking their medications. I emphasize that they will not pass HIV on to sex partners as long as their viral load remains at a very low level, such as below 200 copies. The studies that led to the message of undetectable equals untransmittable, or U equals U, defined undetectable with a viral load of either less than 200 copies or less than 400 copies. And so, really, as far as I'm aware, there has never been a documented HIV transmission with a viral load in that range. So I do reassure people who are taking their medications, who are coming to their visits, even if their viral load is detected below a level of 200 and it remains at that level, that they are doing really, really well. The Department of Health and Human Services adult and adolescent HIV treatment guidelines recommend that with low-level viremia, clinicians recheck the viral load at least every 3 months. I would say that in general, I agree. I typically do not see a reason to recheck the viral load more frequently than that once I establish that the results are consistent with low-level viremia. Now, I do find that low-level viremia is more likely in individuals with very high pre-ART viral loads, meaning a baseline viral load that was in the hundreds of thousands or millions. Presumably, this is because the reservoir of HIV in the person's body is relatively robust. Studies of potential mechanisms of non-suppressible viremia have identified a couple of possible explanations for this occurring. One is activation of virus in the latent CD4 positive T cells that have undergone clonal proliferation. That may be the most likely explanation. I do think this is an area worthy of further study, so we better understand it. So another question I'm commonly asked is for a person with low-level viremia, should the ART regimen be changed or intensified? And in general, I say no. One thing that comes up for me with low-level viremia is I tend to feel more comfortable if the individual is taking a regimen that has a relatively high barrier to resistance. So that would be a regimen with bictegravir, dolutegravir, or boosted darunavir. And that is simply in case missed doses are contributing to the low-level viremia. That is not particularly guidelines or data-driven, but I definitely feel more comfortable if a person is taking a regimen that is relatively more forgiving of missed doses, especially if I'm seeing these low detectable viral loads. Again, it is not absolutely necessary to change the regimen, but I have a low threshold to recommend changing or updating the regimen to a bictegravir or dolutegravir, or if necessary, boosted darunavir-based regimen in the setting of low-level viremia. Now, the reason to monitor the viral load every 3 months with low-level viremia is to catch an instance of viral rebound up to the range of virologic failure relatively quickly and act on that relatively quickly. But let's talk about virologic failure and how it differs substantially from a blip or from low-level viremia. So virologic failure is really important to recognize. So if a viral load is below 200 copies and then rises to above 200 copies, or especially if it rises to above 500 copies, I would call that virologic failure. Another thing that happens, though not as commonly, is if a person starts ART, they are taking ART and their viral load comes down, but not all the way to below 200 copies. That could be considered virologic failure and would be another instance in which not yet detected resistance mutations could be affecting the success of the ART regimen. Now, whether it is a rebound of virus to above 200 copies or a viral load that does not decrease to a level below 200 copies, I do consider checking resistance testing in either of those scenarios. So I think in this situation, genotype resistance testing really should be considered. And if a person is taking an integrase strand transfer inhibitor or integrase inhibitor, then making sure that resistance testing includes an integrase genotype or check for integrase resistance is really critical. So again, if a person's viral load rebounds to above 200 copies or doesn't come down to 200 copies, I consider checking resistance testing. And here I'm referring to RNA or more traditional genotype resistance testing. Now, one caveat to that is if a person is taking a regimen with relatively high barrier to resistance, again, that's dolutegravir, bictegravir, or boosted darunavir, and let's say they miss doses or they have a stoppage, a break, a gap in ART, and their viral load rises, because resistance to those specific medications is so rare, often what I will do is simply recommend that they restart that regimen, come back every 4 weeks for a repeat viral load check, and then I will send the resistance testing if that viral load does not come down appropriately. Now, this is assuming that they didn't stop the regimen because of side effects, toxicity, tolerability issues. In that setting, obviously, I wouldn't recommend restarting. But if that wasn't the case, if it was a gap because of insurance issues or other factors, and the viral load has come up with those specific regimens, often I will recommend the person restart, come back every 4 weeks, we'll monitor the viral load very closely and repeat the RNA genotype if the viral load does not come back down appropriately. Now, it's very different, in my opinion, if a person has virologic rebound while taking a regimen that does not have a relatively high barrier to resistance. So this would be a regimen with an NN-RTI or with the integrase inhibitors raltegravir or boosted L-vitegravir. If a person has had a gap in taking those or missed doses, or even if they are taking those and the viral load goes up to above 200, then I absolutely send resistance testing. And if they are taking one of the integrase inhibitors, I make sure to check for integrase resistance, because with virologic rebound to above 200 copies, and which really is virologic failure with those specific regimens, I have seen a lot of significant multi-class drug resistance develop. So part of the decision-making, in my opinion, when someone has virologic rebound to above 200 copies, which again is how we define virologic failure, is which regimen are they taking and how high is the likelihood that they have developed new drug resistance. So with dolutegravir, bictegravir, or boosted darunavir, especially if the individual does not have a long history of ART or a lot of pre-existing multi-class drug resistance, the development of new resistance mutations is very, very low. It's uncommon. However, with a regimen with relatively low barrier to resistance, again, that's boosted L-vitegravir, raltegravir, NNRTIs, and other things, then the development of new drug resistance mutations in the setting of viral rebound is much more likely. And I would say I nearly always send genotype resistance testing in that scenario. So overall, what we've talked about is the differentiation between a viral blip, a one-time transient increase of the viral load to a level below 200 copies, persistent low-level viremia, which is detectable viral loads below 200 copies over time, and virologic failure, which is a rebound of the viral load to a level above 200 or especially above 500. That defines virologic failure. So it's really important to differentiate these, and the evaluation, counseling, and management is different. I think with blips, it's really key that they are common and generally harmless. With low-level viremia, it is more unclear whether finding those low detectable viral loads over time indicates a higher likelihood of virologic failure in the future or not. Again, the data are conflicting. In my clinical practice, I have not seen a lot of virologic failure develop as an outcome of persistent low-level viremia, but it could happen. So we monitor viral loads about every 3 months. And then with virologic failure, I think the decision-making really comes back to what regimen is the individual taking, why did they have a gap in ART adherence or missed doses, if that was the cause of the virologic rebound, and then should you recommend or check resistance testing if someone is taking their medications every day and their viral load rebounds? Absolutely, I would check. If someone is taking a regimen with a relatively low barrier of resistance and the viral load rebounds, I absolutely would check. If someone is taking a regimen with a relatively high barrier to resistance, there was a clear reason for the virologic rebound, like a gap in medications or missed doses, and the explanation for virologic rebound was not side effects or toxicity, then I may recommend they simply restart their regimen if they are open to that and come back every 4 weeks for viral load monitoring. So again, blip and low-level viremia and virologic failure are distinct clinical processes. It is really essential in practice to differentiate them. to be able to counsel patients about the unique causes, the unique clinical implications, and the management options for each of those scenarios.
Thank you, Dr. Wood, and many thanks to you, our listeners, for joining us. To listen to other episodes in this series on Testing Smarter, state-of-the-art strategies for today's challenges in HIV and STI care, please click the link in the show notes. To get access to all of our new podcasts, subscribe to the CCO Infectious Disease Podcast wherever you get your podcasts.